Good afternoon, everyone, and welcome to today's webinar, Frailty Assessment, a crucial component of the kidney transplant candidate evaluation. We're glad that all of you could join us, and we have a terrific presentation planned for you today. My name is Corey Bryant. I'm the Communications Manager for the Alliance, and we have just a few logistical items to go over before we begin today's program. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner. If you have any questions that come up during the webinar, feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, we are recording this webinar, so we will not be opening the phone lines. That means that all questions must be submitted electronically using the chat feature. Registration is currently open for our upcoming innovation webinar entitled Immune Tolerance in Transplantation, the Holy Grail or an Attainable Goal. So be sure to join us for that on April 5th at 2 p.m. Eastern. Registration is also open for our next Get Connected webinar entitled Building a Culture of Donation Through Effective Hospital Association Partnerships. That's coming your way on April 10th at 2 p.m. Eastern. So please note that all of these webinars will be occurring in Eastern Daylight Time from now on. You can register for all of these webinars and more on our website at organdonationalliance.org. Now, for today's webinar, we are offering 1 SEPC credit and 1 nursing contact hour courtesy of Iowa Donor Network. Everyone listening in on today's webinar is entitled to claim continuing education credits. So if you're listening in a group, and we know that many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 days to claim your CEs, and for SEPCs, you will have 30 calendar days. At this point, I would like to introduce our moderator, Ms. Becca Brown. Becca is the Nurse Manager for Transplantation Services at UPMC Pinnacle in Harrisburg, Pennsylvania. She's also a member of the 2018 Alliance Webinar faculty. So Becca, we're glad to have you with us, and at this point, I will turn it over to you to introduce our speaker.
Thanks, Corey, and good afternoon, everybody. I have the pleasure of introducing Dr. Mara McAdams DeMarco. Dr. McAdams DeMarco is an assistant professor of epidemiology and surgery at the Johns Hopkins University Bloomberg School of Public Health and School of Medicine. Her research focuses on the intersection of aging and end-stage renal disease, with a particular focus on the utility of frailty assessment to improve post-transplant risk prediction. She is a member of the Older American Independence Center and Frailty Working Group through the Center on Aging and Health at Johns Hopkins. Dr. McAdams DeMarco, thank you so much for sharing your expertise with us today. I'm going to hand it over to you now.
Thank you very much. Well, I'm very honored to have this opportunity to be speaking to this group about our work on frailty today. And I hope by the end I'll be able to convince you that this frailty assessment that we'll be discussing today is really an important and crucial component of the evaluation of a kidney transplant candidate, in particular an older candidate. I have no financial relationships to disclose. And I want to start here with a focus on older adults. If we look at the American Society of Transplantation recommendations, they suggest that there should be no absolute upper age limit for excluding patients based on their overall health and life situation that suggests transplantation would be beneficial. So if there's no overall upper age limit in deciding who should and who should not undergo kidney transplantation, we really then must rely on other measures of age other than chronologic age. Now, I don't need to explain this to this type of group, but we all have to recognize that this pathway to transplantation is often quite complex. Let's focus on the deceased donor kidney transplant candidate. First, someone must actually educate this patient about kidney transplantation. Their nephrologist then must refer them to a transplant center. After they've been referred, they must undergo evaluation for transplantation. And if they're pursuing a deceased donor kidney organ, then they will be added to the deceased donor kidney transplant waitlist at that transplant center. Then they must go on and an organ must be accepted on their behalf by the surgical team. And so at each one of these stages, we have to think, how are we going to be able to decide which patients should be undergo kidney transplantation, and really will have the ability to undergo and tolerate that stress of transplantation. This is such a major surgery that it is important to consider who should undergo transplantation and who has the ability to withstand the surgical stressor. So when we think about stressors and the ability to tolerate those stressors, this automatically leads me to think about frailty. And the reason we like frailty is that it gives us an extra piece of information when considering different candidates. It allows us to be able to consider who would be a good candidate for transplantation and who would not, based on characteristics beyond just chronologic age. So I'm going to have a quick thought exercise before we move on to the meat of this presentation. Imagine that at your center, you have two candidates who have come in on the same day, and you're trying to decide who would have better outcomes after transplantation. If we have one candidate who's 42 years old, the other is 68 years old. These two candidates have exactly the same comorbidity burden, they have the same level of disability, they have the same education. All factors are similar between these two patients. So who do you think then would have the better outcome? Well, I guess the majority of you would decide that the younger candidate would have better outcomes. What happens if I added just yet one more piece of information that would be measured as part of the evaluation? What happens if I told you that that younger candidate was in fact frail, whereas the older candidate was not frail? For many of you, I bet this changed your decision about who would have better outcomes after kidney transplantation. So let's actually walk quickly through the numbers here to give you a sense of the differential outcomes in this older and younger candidate. And this is work that we had developed from our research that we'll be getting into further on in this discussion. So if you look at important outcomes like delayed graft function, a longer length of stay, early hospital readmission, and post-transplant mortality, what we see is that there are similar rates of delayed graft function in our younger frail candidate and as with our older non-frail candidate. If we look at the longer length of stay, we see that the younger frail candidate is more likely to have a longer length of stay. The younger frail candidate is also now more than twice as likely to have an early hospital readmission. And importantly, that younger frail candidate is twice as likely to have experience post-transplant mortality than the older non-frail kidney transplant recipient. So what this suggests to us is that frailty is capturing some other unique domain of risk that would be helpful and useful in deciding which kidney transplant candidates would have better outcomes after transplantation. So let's actually spend some time now just talking about the construct of frailty and how we measure this phenotype. So frailty was a phenotype that was originally identified in community-dwelling older adults and has been subsequently validated in this population. It was first identified by Dr. Linda Fried in 2001, who was a geriatrician at Johns Hopkins University. 10 years ago, we began studying frailty in patients with end-stage renal disease. And to just give you some context, we've been doing observational studies over these past 10 years in patients who are on the kidney transplant waitlist at Johns Hopkins and at University of Michigan, as well as patients undergoing kidney transplantation at these two universities. We currently have nearly 4,000 patients on the waitlist that are enrolled in our prospective cohort study. We also have just over 1,290 kidney transplant recipients who are also enrolled in this study. And as you've been able to move through time, we look at longer and longer term outcomes. And I hope through today's presentation we'll give you a little bit of a deeper insight into frailty as a phenotype, as well as how it's pertinent to the kidney transplant candidate. In community-dwelling older adults, this phenotype was developed. The idea was to capture a patient's physiologic reserve or their resistance to stressors. That really answers the question of how well will this patient bounce back after a major stressor like surgery. The Fried frailty phenotype is a multi-component syndrome, and if you see the figure on the right, it has both physical and self-reported components. They include decreased walk speed, which is directly measured, exhaustion, which is self-reported, decreased grip strength, which is measured, low physical activity, which is reported, and unexplained weight loss, which is reported. The original phenotype was developed in community-dwelling older adults in the cohort that was called the Cardiovascular Health Study, which is comprised of 5,317 community-dwelling older adults. And what the original paper found was that 7% of this older adult population was frail, and within the next 3 years after cohort enrollment, 7% developed incident frailty. If we take a look at the measurement of this phenotype, it's really comprised of some simple measurements for each of these 5 components. The first component of shrinking is measured by unintentional weight loss of 10 pounds or more in the past year. And I'll mention here that we've adapted this criteria to be specific to end-stage renal disease patients, such that the unintentional weight loss of 10 pounds is of dry weight, again, over the time period of 1 year. Weakness is determined by grip strength, which is measured by a dynamometer and is adjusted for gender and body mass index. Exhaustion is reported by 2 questions that are from the Modified Centers for Epidemiologic Studies Depression Scale. And low physical activity actually quantifies a leisure time activity through the Minnesota Leisure Time Activities Questionnaire. It assesses a patient's physical activity in the past 2 weeks. Finally, walk speed is directly measured over the average of 3 trials that are done over 15 feet with participants walking at a normal pace. Any patient who has 3 or more of these components we identify as being frail. So it doesn't matter which components as long as you have 3 or more. We now measure this frailty phenotype as is described on this slide at the time of evaluation for transplantation, and additionally at admission for transplantation. It takes less than 10 minutes to measure and can really easily be done as part of the clinical evaluation or the admissions process for transplantation. One of the reasons that we've always been very interested in studying frailty is that it's separate but related from disability and comorbidity. This is a Venn diagram from the original publication. And what it shows here is that there are patients who are frail that also have disability. There are patients who are frail that also have comorbidity. But strikingly, over a quarter of these community-dwelling older adults were frail without having any disability or comorbidity. This suggests that it captures a unique domain of risk, that knowing someone's chronic disease conditions or their disability status really won't be enough to identify those who are frail. Importantly, we see that there are many patients who do share frailty, disability, and comorbidity, but you can still identify those who are frail regardless of their comorbidity and disability status. Now let's look at this phenotype in patients with end-stage renal disease stratified by their renal replacement therapy. And again, I just want to highlight here that these are patients with end-stage renal disease of all ages. We've added a column for the cardiovascular health study to give you a reference to community-dwelling older adults on the end of this figure. And what we see here is that 44% of dialysis patients are intermediately frail, whereas 46% of dialysis patients are frail. Among patients who are on the kidney transplant waitlist, 53% are intermediately frail and 26.8% are frail. And finally, for those patients who are on the kidney transplant or who have received a kidney transplant, 58% of them are intermediately frail at the time of transplantation, and 21.5% are frail at the time of transplantation. And again, this is a striking burden of frailty as compared to the cardiovascular health study, in which only 6.9% of community-dwelling older adults were frail. Now, as I mentioned earlier on this slide, this measurement of frailty we have now conducted on kidney transplant candidates and recipients of all ages. The question then arises, well, is it just a difference in age between our population and the community-dwelling older adults? What we see here on the next slide, we've stratified the prevalence of frailty by age. And you see, regardless of whether the patient is on dialysis, whether they're on the wait list, or they're undergoing transplantation, there's a higher burden of frailty at all ages as compared to community-dwelling older adults. And this really fits nicely with the theory of accelerated aging in end-stage renal disease. Let's first talk about our results on studying frailty among kidney transplant candidates. So as I mentioned earlier, we've been conducting a prospective cohort study of kidney transplant candidates. We have nearly 4,000 kidney transplant candidates of all ages enrolled in our study from 2 sites. And over the past 5 or so years, we've really focused on this kidney transplant candidate cohort and found that this is a highly vulnerable population to adverse events while waiting for transplantation. So we have found that in kidney transplant candidates, frailty is associated with a 2.7-fold increased odds of fair or poor health-related quality of life. That would be at the time of evaluation. And really importantly, those who were frail had the steepest decline in health-related quality of life, such that they were at a 2.9-fold increased risk of declining health-related quality of life while waiting for a kidney transplant. Additionally, we found that frail kidney transplant candidates are at a 2-fold increased risk of waitlist mortality. And if you see here in this figure, there's a steep rise in the risk of mortality. So what we have in this figure is the years since evaluation on the x-axis, and on the y-axis we have the risk of mortality by each year. And if you see the dark black line, that's the highest, that suggests that kidney transplant recipients kidney transplant candidates, who are frail, have the highest waitlist mortality. Let's then move on to our results looking at frailty among kidney transplant recipients. And again, just to highlight, this is a cohort of 12,000 kidney transplant recipients in which we've measured frailty at admission for transplantation. What we see in this first figure is the frailty scores, which is a score of 0 to 5, as I previously mentioned. And we find that among all of our kidney transplant recipients, there's a high burden of frailty, such that 20% of those are frail. And even among those who are non-frail, there's still there's still a high burden of intermediate frailty in this population too. And this is highly striking, especially to my colleagues in geriatrics and gerontology, as this is a younger population than frailty is typically studied in. One of the questions that we had early on in our research was, who are these kidney transplant recipients who are frail? What are the characteristics of these kidney transplant recipients that would make them likely to be frail at the time of transplantation? And my main question here was trying to figure out whether it was end-stage renal disease factors that are leading to frailty, or whether it would be other measures of aging that would be associated with frailty in this population. And so we looked at both intermediately frail status as well as frailty status here, and I think it's easiest to just focus on the frailty status. And what we saw was, as expected, age is highly associated with frailty status, such that older kidney transplant recipients are about 2-fold more likely to be frail at the time of transplantation. We saw no differences by sex or by race or by obesity status, but we did see a strong relationship with the instrumental activities of daily living disability, such that patients who had this type of disability were at a 3-fold increased odds of being frail at the time of transplantation. Again, strikingly, we saw that depressive symptoms, as measured by the Centers for Epidemiologic Studies Depression Scale, was, again, strongly associated with frailty status at the time of transplantation, as was lower educational ascertainment. We did not see any differences with smoking status, with residual kidney function, or with the donor type. We can focus on some more of these correlates here. And again, focusing on frailty status, we saw that there was no association between the time on dialysis in a patient's frailty status, nor their cause of end-stage renal disease with frailty status. But quite interestingly, we saw, again, a strong association between a patient's self-reported health-related quality of life and frailty status. So patients who reported good or fair or poor health-related quality of life were much more likely to also be frail at the time of transplantation. What's really interesting to me about these initial findings that we had was that it suggests that frailty really captures these unique domains of risk that aren't necessarily measured as part of the transplant evaluation process. What we see is that these common markers of duration or burden of end-stage renal disease are not associated with frailty status, but yet patient-centered metrics like health-related quality of life and disability are. Looking at the adverse outcomes associated with frailty, we have found that frailty is again a phenotype of high risk in our kidney transplant recipient population. So once we've measured frailty at the time of transplantation, we find that frailty is associated with a 1.57 times increased odds of a longer length of stay, which we defined as 2 weeks or longer. We also found that frailty is associated with a 2.2 times increased odds of post-transplant delirium. And this is interesting work that should be that is under review now. This really helps connect the brain-body connection and has been observed in other surgical specialties, but never before in kidney transplant recipients. We also found that frailty is associated with a 1.6-fold increased risk of early hospital readmission, which is the readmission to any hospital within 30 days of discharge from a kidney transplant. And I really have always found this to be an intriguing work of ours that highlights this difference between chronologic age and physiologic age. Here in this figure from that paper on early hospital readmission, we have the early hospital readmission rates plotted on the y-axis by patients' chronologic age and their frailty status. What we see if we focus in on the two bars in the center, that younger patients who are frail were more likely to have an early hospital readmission than older recipients who are non-frail. And in fact, the early hospital readmission rates between younger and older frail kidney transplant recipients were very similar. And this to me suggests that the driver of early hospital readmission is not necessarily chronologic age, but it seems to be driven a lot more by the patient's physiologic age and their ability to withstand the stressor of surgery. Again, we found that kidney transplant recipients who are frail are at a 1.9-fold increased risk of delayed graft function. And while this is originally an interesting finding from our research group, it's highly plausible given the strong connection between frailty and systemic inflammation. We think about frailty as being a state of heightened inflammation, and we found in colleagues have found in previous work that frailty is associated with increased IL-6 and TNF-alpha receptor 1. We believe that that is part of the pathway that explains the association between frailty and delayed graft function. We also found that frailty is associated with a 1.29-fold increased risk of MMF immunosuppression intolerance. When we, in the follow-up of our cohort, we found that these frail kidney transplant recipients were experiencing more side effects of MMF than their non-frail counterparts. And the side effects were so bad that they were receiving a dose reduction of MMF. Sadly, when we followed this cohort longer, we found that those who were frail, who then experienced the MMF intolerance, were then the most likely to go on to have a subsequent graft loss, which really links, I think, these pathways between frailty as a measure of decreased physiologic reserve and an inability to withstand the stressor to long-term adverse outcomes. And finally, we found that frailty is associated with a twofold increased risk of both kidney transplant mortality. And so when we look at these results from our kidney transplant recipient cohort, we see this expanding pathway in which frailty at the time of admission for transplantation is associated with both short-term outcomes as well as long-term post-transplant outcomes. And we see that patients' frailty status really puts them on different trajectories post-transplantation. Now, I get a question quite often when I'm talking about frailty that pertains to the measurement of frailty. As I mentioned before, we are able to conduct this as part of routine clinical care by measuring patients' frailty status at the time of evaluation while patients are visiting our center. We also measure it at the time of admission for transplantation. And I've often gotten the question that, well, don't we just know who's frail? Can't we just look at a patient and see which patients are frail and which patients are not frail? So the gist of it is, do we need to actually walk through the phenotype and measure each of these 5 components? Because yes, it seems trivial, but 10 minutes of clinical time is always important. So let's actually explore some of the literature then to determine the best way to identify which patients are frail. We conducted a study early on of dialysis physicians and nurse practitioners in a dialysis setting to find out whether they were able to identify which of their hemodialysis patients were frail. And what we found was that there was little agreement between the physician and the nurse practitioner's identification of frailty and our direct measurement of frailty in this dialysis population. So the percent agreement was only 64% for physicians and 67% for nurse practitioners. This is really findings that are only kind of slightly better than by chance alone. I think the most striking part of this research to me was that the obese patients and the African American patients were more likely to be misclassified, meaning that they were less likely to be identified as frail. This really concerns me, as these are 2 potential pathways that could increase disparities in access to transplantation. Furthermore, we conducted another study of 460 patients that were being evaluated for kidney transplantation. Interestingly, when we asked patients, we described to them what the phenotype is meant to measure, and we asked them to identify whether they thought they were frail. Only 13% of our frail patients who were undergoing evaluation for kidney transplantation thought that they were frail. And even some of the non-frail patients thought that they were frail. This really allows me to kind of step back and think about who is able to assess and identify frailty. Clearly, patients are not able to fully capture this. They may understand that they have some of the symptoms, but not necessarily self-report all of them. Secondly, this reminds me that while our physicians and nurse practitioners really know that these kidney transplant candidates and dialysis patients the best and have a very good and strong connection with them, they may not be able to pick up on some of this multi-system dysregulation that's occurring for these patients. We also asked our clinicians whether they thought these 5 components of frailty were appropriate. So again, the 5 components for frailty are shrinking, they are decreased walk speed, low physical activity, decreased grip strength, and sedentary behavior. And unfortunately, this was developed in community-dwelling older adults. So one of the questions that we've always had was if there's a way to make this measure of frailty more specific to an end-stage renal disease population. And to do this, we've surveyed physicians and we asked them their opinions on each of the components of frailty. And what we found was that the majority of these, that 26% of the clinicians we surveyed, believed that the construct of unintentional weight loss really may not be relevant to end-stage renal disease patients. And this is particularly true given that there's substantial weight fluctuations in patients who are undergoing dialysis prior to transplantation. We also then asked these clinicians whether there were other components that they may find to be more pertinent to an end-stage renal disease population. They identified a history of falls as being important, physical decline, particularly over the time of evaluation for transplantation, cognitive impairment as being important, nutrition and diet being an important component, albumin, and then less so healthcare utilization, metabolic bone disease, excess fluid, and ultrafiltration. And at the end, I will be able to direct you to a survey if you're interested in providing such input to us. So the second question that I often get about this frailty phenotype in an end-stage renal disease population that's undergoing evaluation for transplantation is whether or not there are alternatives to the frailty phenotype that would be completely objective. As I mentioned at the start of this talk, frailty, as is described by this phenotype, includes components that are subjective. And this becomes a question when thinking about using frailty as a way to identify appropriate candidates for transplantation and prioritize them. The question arises as to whether frailty can be gained to be able to gain access to transplantation. And so we've explored other alternatives that are completely objective. And the one alternative that we've identified and studied so far is the short physical performance battery. It's the SPPB. It's a common measure, again, from geriatrics and gerontology that focuses on lower extremity function with respect to walk speed, chair stands, and balance. And what we see is that the SPPB is a measure of lower extremity impairment that's quite common among kidney transplant recipients. In fact, we found that over 46% of our population had this lower extremity impairment. In this Venn diagram, the other kind of striking piece of information to me that comes from this is that only 11% of our population had both the impairment, the lower extremity impairment, as well as frailty status at the time of transplantation. And in fact, 5% of our population was frail without a lower extremity impairment. This suggests to me that frailty is a more global measure that's not limited to lower extremity impairment, or not solely limited to lower extremity function. My concern with using the short physical performance battery as a completely objective measure of physiologic reserve is that it actually captures a very large number of kidney transplant recipients who would be potentially identified for either further interventions or would potentially be limited for transplantation. However, we did see that the short physical performance battery measurement of lower extremity function was associated with an increased mortality risk. So again, like the last figure, this is a figure here of number of years since transplantation and the percent of mortality on the y-axis. We see that from even early post-transplantation, those who had a lower extremity impairment measured by the short physical performance battery had an increased risk of mortality. And after adjusting for all potential factors that may be explaining this association, we still saw that the lower extremity impairment was associated with a twofold increased risk of mortality in kidney transplant recipients. Interestingly, to know it with this short physical performance battery, it is completely objective, but it does require a chair and some more tools to be able to measure walk speed and balance. It's easy, again, like frailty to conduct. It takes even slightly less time than the frailty assessment to conduct, but it is limited in its ability to be generalized to upper body strength. It is only associated and only reflective of a patient's lower extremity function. In a subsequent study, we've looked at the short physical performance battery and the discharge from transplantation. So this is a little bit of a different figure here, but what it's looking at is the changing risk of being discharged. So how likely is a patient to be discharged by their lower extremity function? And what the easiest way to interpret this is that at all time periods up to 30 days post-transplant, a patient who has a lower extremity impairment is much less likely to be discharged from the hospital than one who does not have a lower extremity impairment. Again, in our adjusted models, what we see is that patients with this lower extremity impairment are at an increased risk of staying in the hospital after a kidney transplantation for 14 days or longer. The third question that I get when talking about frailty and an ESRD population, and particularly one who is undergoing evaluation for transplantation, is whether there's anything we can do. And we know this from the studies of older adults. Many don't want to discuss their frailty status, don't want to know their frailty status, because there isn't necessarily a treatment that's known or available to them once they've been classified as frail. So our current work and where we're moving with our research is to better understand how can we improve frailty in patients with end-stage renal disease, and most specifically in those who are undergoing evaluation and waiting for a transplantation. We believe that this population has a unique opportunity to be able to improve prior to transplantation while they wait for either their live donor to undergo evaluation or for a deceased donor offer to come in. What we propose as an option for improving frailty is prehabilitation. This is the idea of not waiting until after a stressor and decline to have rehabilitation, but rather to provide that preemptively to patients prior to their transplantation. So we've been interested in studying prehabilitation for patients who are on the kidney transplant waitlist at our institution. And one of the first things we did was we asked physicians who care for older and frail end-stage renal disease patients about their interest in prehabilitation prior to kidney transplantation. We found that overall, of our 41 physicians, 97% said that they would be interested in having their patients participate in a prehabilitation program. They said that 97% of the physicians believe that this prehabilitation program would make an end-stage renal disease patient less frail, and all believe that prehabilitation overall would help ESRD patients. When we asked patients about these questions on their opinions about prehabilitation, we found that 80% believe that they would be interested in prehabilitation, 84% believe that it would make them less frail, and 93% believe that prehabilitation would be beneficial overall to an end-stage renal disease population. So with that survey data, we began a study of prehabilitation as an intervention trial, as a pilot intervention trial for kidney transplant candidates at our study. In our center, we enrolled 21 patients who were on the kidney transplant waitlist at Johns Hopkins. And what we did was we had them go to an outpatient physical therapy session every week for 3 to 6 months prior to transplantation. They not only went to the outpatient center, but they also received a monthly in-depth assessment from a physical therapist, and they were asked to perform home exercises between each of the sessions. Overall, our participants were able to attend 8.5 sessions on average, and we were able to really recruit quite a diverse group of kidney transplant candidates. The mean age was 52 years, but ranged from 34 to 72. We found that 66.7% of our population was African American, which is consistent with the general wait list that we have, particularly for the kind of local catchment area for Hopkins, and 47.5% were female. Strikingly, we were able to recruit participants who had a higher burden of frailty than overall would be seen on our kidney transplant wait list. So we found that of these prehabilitation pilot study participants, 26% were frail. And this is really important for us because we know that this type of prehabilitation would be beneficial to all patients. We were afraid that we'd only be able to enroll those who were the healthiest. But in fact, we were able to enroll a quite substantial group of patients who were frail. So what we found in looking at some early preliminary data from our prehabilitation trial, we found that after 1 month of this prehabilitation, patients were able to improve their physical activity by 32%. And to measure this, we put on actigraphs, which are similar to Fitbits, but for research grade. And we tested whether there was a change in a patient's physical activity based on their accelerometry in the week before starting the prehabilitation session and in the 5th week of their prehabilitation, enrollment. We found that their activity count before prehabilitation was only 413, which is quite striking. And to give you some context, that's equivalent to community dwelling 75-year-olds mean log activity counts. We were able to increase that to 547 after 1 month of prehabilitation, and this was statistically significant. The other kind of early findings that we found from this pilot study was that, unfortunately, these patients were quite sedentary prior to the prehabilitation, both on dialysis and non-dialysis days. And in fact, they were moving more on dialysis days, we think because they had to get up, they had to leave their house, they had to go somewhere and walk around. They really spent that non-dialysis day recovering. So they were taking some of that time of recovering it and using it to increase physical activity. We saw improvements overall on both our non-dialysis days and on our dialysis days. And while I think the statistics is all very important, to me the most important feedback that we've gotten on this prehabilitation pilot by far is the feedback that we've received from patients. We've had 100% of our participants report that they are very satisfied with the prehabilitation program. And just anecdotally, we hear from patients that this is really important to them because it's the first time that somebody is asking them about their health concerns that aren't related to their kidney disease. They feel like every time they go to a physician, they feel that the attention and focus is on their kidney disease, but they want to be able to talk about their back pain. They want to talk about their knee pain. They want someone to help them be able to walk up the steps and have more energy to do that. So we feel that this prehabilitation program has been successful, not only because it restores physical functioning, which is a key component to our frailty assessment, but it also is able to provide more assurance for patients as they move towards this major surgery of transplantation. They feel like they have more support and have a more well-rounded health picture as they move towards transplantation. And with that, I just want to read some of the quotes that we've received from our from the participants in this prehabilitation pilot program. They've reported things like better endurance and more energy. They say that the proactive approach is making me stronger. They say the exercise program has helped me get all the kinks out of my body. It helps me to work and gives me better outlook on what I'm doing. They report things like saying I sleep better, I feel stronger, and I have more endurance. It has helped me to lose the weight that I need to lose. The overall experience is great, and I think it'll be great for other people if they took the time to try it. And they do, my favorite one I saved for last. They said I'm feeling good and feeling empowered and feeling good. And this is really what we want the patients to be able to do. We want this prehabilitation that is largely driven by a physical therapy intervention to also be able to help patients to have the kind of psychosocial support needed to move towards transplantation. If they have a better outlook on their health and how they're doing, this will allow them a chance to be fully prepared both physically and emotionally for undergoing transplantation. We're hoping to expand this study to do more in-depth testing, and most importantly, we're looking to see whether the prehabilitation pilot program has improved post-transplant outcomes. But unfortunately, that work is still to be done, so I hope to report that sometime soon. So in summary, I hope today that I've been able to convince you that the frailty phenotype is a measure of physiologic reserve and a patient's ability to withstand a stressor that's easily measured both at the time of kidney transplant evaluation as well as at admission for kidney transplantation. We've had 10 successful years of measuring this as part of routine clinical care. Our patients are more than happy to be providing this information to us, and they're happy to be doing the assessments, and we've been able to roll it out without interrupting any of the clinical care that's going on during the time of evaluation or for the admission for kidney transplantation. Importantly, we saw that frailty is associated with adverse outcomes among our kidney transplant candidates and recipients. Even if they were younger recipients or older recipients, frailty is bad regardless. We found that there are alternatives to using the frailty phenotype that are completely objective, such as the short physical performance battery as a measure of lower extremity function. The problem, though, with using this other measure of lower extremity function is that it doesn't have great overlap with the frailty phenotype. And we think of it as capturing a separate domain of risk, this lower extremity function. Maybe missing some more important physical components as well as the social emotional components that are captured by the frailty phenotype. When we think about whether or not it's important to measure frailty in our patients, we find that it is crucial to measure the phenotype as it was described originally in community-dwelling older adults. And that's because we found that neither patients nor their providers were fully able to determine which of the dialysis patients and patients being evaluated for kidney transplantation were frail. In fact, they needed to be measured at all times. We do, however, have some evidence that this phenotype with the 5 components may be useful for community-dwelling older adults, but not all may be translated easily to an ESRD population. In particular, we're doing some work now to better understand that weight loss component and if we can better tailor that to an ESRD population who has substantial fluctuations in weight due to dialysis. We also found some striking results on the clinical measurements of frailty not being associated with, clinical measurements of end-stage renal disease as not being associated with frailty status. In fact, we think that frailty is capturing this unique domain of risk that is separate from their disease progression, but and slightly more related to their aging metrics. We found some preliminary and early evidence that prehabilitation may be an important and feasible intervention that can really help get a patient who is waiting for transplantation primed and ready for that major surgical stressor that they'll undergo with transplantation. Our work is really preliminary for prehabilitation, but we believe that it's right now the most feasible and most likely intervention to help these candidates to really be ready to undergo transplantation. We hope to see that with future studies, this prehabilitation intervention is a true way to prevent post-transplant adverse outcomes that are associated with frailty. So I want to end with one other thought about how do we take this measurement and really incorporate it into routine clinical practice. We believe that frailty is useful for the transplant management of a patient when measured at the time of transplantation, but really where it has the most ability to help with the clinical decision making is as part of the referral process or the transplant evaluation process. So if we think back to the earliest slides I presented, there are numerous decision points in which a patient must be decided whether they're willing to move through that pathway for transplantation. We believe that measuring frailty at these times will help better inform that clinical decision making. Really importantly, it won't allow us to solely look at chronologic age. Chronologic age is easy to measure. It's simply a patient's age, but it actually is giving us a very incomplete picture. We believe that frailty is going to be useful for transplant surgeons when they're deciding whether or not to accept a marginal candidate who are otherwise physically robust. It will help to be able to decide against transplanting candidates who are really not going to be able to withstand the transplant procedure. In fact, for these candidates, it may be better for them to remain on dialysis. And really, to me, one of the most important and crucial ways to think about the frailty phenotype as part of recipient selection process is to help us to identify the older candidate who really would do well with a transplant despite their age. It really gives you a counterpoint or a balance to the measure of chronologic age. And finally, as we alluded to in the last pilot studies, we believe frailty is a great way to be able to identify those candidates who just need a little bit something more to be able to get them through the wait time for transplantation. They just may need to be a little bit stronger or lose a little bit more weight, and ideally this would be a way to identify candidates who need prehabilitation. I hope I've interested you in measuring frailty at your center. If you would like more information on how to measure it clinically or how to implement it, please feel free to contact me. Also, we are in the last week of conducting a national survey on what is being used and what is being considered frailty in the field of kidney transplantation. If you're willing to and would like to answer this national survey for us, again, please contact me by email, and I'm happy to send you the link. We really are trying to get as nationally representative a survey as possible. My email is listed on this final slide, and I thank you for listening today, and I also thank my mentor, Dr. Dory Segev, at the Epidemiologic Research Group on Organ Transplantation, as well as the faculty and staff who work with us and collect this really important data on aging and transplantation. Thank you very much, and I'm happy to answer questions.
Thank you very much, Mara, for such an insightful presentation. Before I turn it back to Becca for questions, just as a reminder for everyone, if you do have questions for our presenter, please submit them using the chat feature in the bottom left-hand corner of the screen. While we are doing the Q&A time, I will also have this poll up. For those of you listening in a group, please complete this poll and let us know how many people were listening in your group. That's very helpful for us. And at this point, I will turn it back to Becca to moderate our questions.
Thank you very much, Dr. McAdams DeMarco. That was a great talk. I guess one of my questions is, while we're waiting for the other questions to come in, is if you can measure this during clinical practice, like who does it? Is it a coordinator does the measurement? Is it a physician? Like, how do you do it?
Yeah, that's a great question. When we started early on, we really had research assistants. These were young, kind of post-college, transitioning to med school, young adults who were kind of eager and would get, at the hospital at all hours of the day to do this for us. And I think that's absolutely perfect for research, but the question that's most relevant is who should be doing this as part of routine clinical care. In the past, we've had our MAs, we have them trained, and they're able to measure this really with no problems at all. We have had, very highly seasoned researchers confirm the MA's assessments, and we've been very happy with our results. We do feel that it's important to educate whoever is measuring frailty that this is an important measure that's similar to taking a patient's blood pressure. We're really getting yet another vital sign for this patient. We've also asked this question for our national survey, and what we find is that most commonly it's either physicians or nurses who are measuring frailty at different centers. We think that is important and good, but we really do believe that it could be done by a nurse or an MA and then be ready as part of that discussion.
Thank you. We have all kinds of questions coming in here. So the first question is, who pays for the cost of the prehab program, and what is the cost to the participants?
That's a great question. So we have only done this now as part of research. And you're right, that is something that I kind of completely left out of this. So we had a pilot grant from our Older American Independence Center to study this. It was an NIH-funded study. So we paid for the prehabilitation sessions directly from our research grant. There was no cost whatsoever to the participants, and we allowed participants who didn't have transportation to the outpatient physical therapy, physical medicine and rehabilitation center. We paid for transportation to them. This is a very, very costly study because of this. And part of what we need to do kind of moving forward is really think about, number one, testing the efficacy for post-transplant outcomes, testing the real-world effectiveness of this intervention, and then third, thinking about employing some sort of implementation science type research to understand how do we take it from this, NIH grant-funded research to actually enrolling it into to clinical care, which would be covered by either insurance or by the transplant center. What we hope to do is show that prehabilitation is cost savings enough that we'd have multiple stakeholders who'd be willing to pay for that upfront cost to prevent subsequent outcomes and the cost associated with them later on. But again, this is very preliminary for that. That's what I'm hoping to see.
Mm-hmm. The next question is, have you correlated the EPTS score with frailty?
Oh, yeah, that's actually a great question.
It is.
Yeah. No. So the quick answer is no. What I can tell you is that I never published this, but last year I presented this at the American Transplant Congress. EPTS has horrible predictive ability for mortality for older kidney transplant recipients. It has a C statistic of 0.56, which means the model predicts who's going to die and who's going to live only slightly better than a flip of a coin. So you're right. I think that would be interesting to look at, and thank you. I'm getting a lot of that out of this.
And then one of the other questions is, are there nutrition interventions that are included in the prehabilitation program?
Yes. So we have not gone that route. What we know from the literature on interventions for frailty among older adults is that they're often multimodal interventions that target nutrition, target exercise, target depression, mental health too. We didn't do nutrition purely because I just didn't have the expertise, nor did we have a colleague that really had those expertise in this population. I do agree that probably moving forward I would probably widen the scope of prehabilitation to include a smoking cessation component, a nutrition component, as well as this exercise physical component too.
And one of the other questions is, how often and when do you repeat the frailty assessment? Like you say you do it at evaluation. If you recognize that they're at risk, do you retest them before you get to that time of transplant, or?
Yeah. So that is actually a question we are addressing right now. I have a master's student looking at the changes in frailty between evaluation and transplantation. The way that we've always measured frailty at our center was during the routine care, and it's only been within the last few years that we've brought patients back in as they moved up on the wait list. So basically patients came in at evaluation, and then we saw them again at transplantation because those were the only clinical encounters that they were having. We're just starting to get more of that data, but yes, we do measure frailty at every reevaluation. What we see is that it is dynamic. It does change over time. There's a large group who is non-frail that remains non-frail. A significant proportion of the frail patients remain frail between evaluation and transplantation, but there's about, I think, 15 to 20% of our population whose frailty status is dynamic. And so we're just starting to explore that, and I hope within the next 6 months or so to have a publication on that, because that to me is one of the biggest questions so far. What does it matter when you measure frailty in this population?
Yeah, because they're waiting so long for a deceased donor transplant.
Yeah.
And one question was, why did you include non-frail participants in the prehab study?
Yeah, that was just out of feasibility. We are the one limitation to doing the prehabilitation, as I described there, was that patients had to be live within a catchment area of our outpatient PM&R center. And that really limited the number of people who were eligible to do the study. We do have frailty as a score, so we're exploring the kind of degree of frailty as a score of 0 to 5, how that's influenced. So everyone was above a score of 0 for the pilot.
And this is an interesting question. It says, given the length of time that patients are on the waiting list, how often do you recommend reassessment? And do you make any adjustments for patients who are amputees, and when would you incorporate that into the SPPB testing?
Yeah, these are, again, great questions. So this kind of gets into the nuts and bolts of the measurements. What we do is we do not, for patients who either have to use a device for walking, so they use a walker, they have a cane, if they're able to ambulate but do a prosthesis for amputation, we do note that as part of their walk speed and can account for that. We kind of give them a little bit of their own, a little bit of the leg up. Oh gosh, no. We give them a little bit of an adjustment there. Sorry, that was it's complicated. What we've done is we've tried to stick to the definition as was presented in the original publications. Same thing for grip strength too. We don't measure that in patients with arthritis for obvious reasons that we wouldn't want them to have to perform a test that was painful.
Yeah, and then for the self-reporting aspects of the test, do you feel that patients are honest or kind of game the results because they'll say or do anything to get on the transplant list and get a transplant?
Yeah, so we make it very clear that this is research purposes. This is not going to impact, your listing. We're really not at the point, of making it the factor that decides whether or not they would get a transplant. We believe it's too early for that and probably not appropriate. Yes, I believe that patients, when they see our research assistants wearing white coats, they're going to report feeling better, and there's always patients who have that willingness to please. And this is, I think, reflective in our health-related quality of life measure. Just asking a patient, what's your health-related quality of life from poor to excellent, we have a number of patients with end-stage renal disease who say excellent.
And one of these questions is the poor outcomes of frail patients related to their willingness to accept higher KDPI kidneys?
So that we haven't really seen. And again, a lot of this data was even collected, much earlier on before the inclusion of KDPI. I think there may be some willingness of the physician to accept a higher KDPI on behalf of these patients. We haven't seen that yet, but it is definitely plausible.
Hi, ladies. I hate to jump in here. We have reached the top of the hour. So for our participants that are participating, thank you so much for hanging with us. If you have a few more minutes, you're welcome to hang with us. We're going to try to get through all of these questions here. We have just a couple remaining. If not, we want to be respectful of your time and let you go. But we do have a couple more questions to get to if Dr. DeMarco wouldn't mind.
Sure. And I'm also happy to answer anything that arises later on by email. Just let me know.
So the question is, who should be responsible for the prehabilitation monitoring?
Ooh. Again, this is moving more towards implementation and kind of the real-world use. We had the luxury of having my really delightful project manager who knew these patients well, would go sit with them and meet them over at the center and chat with them. So she was responsible in calling saying, oh, you've got an appointment coming up, make sure you're going. I see this as when it's moved to the kind of the real world use as being part of the transplant coordinator's responsibilities. Again, that's going to really depend on how your center is structured and what would work for your center. But I see them as having that kind of similar warm relationship with patients, knowing these patients well. And to me, that would be a nice opportunity.
And it looks like the final question in the queue here is, in the patients receiving the prehab NPT, do you know what other outcome measured during the monthly visits?
Yeah, so what else is measured? We measure weight, we measure blood pressure, and we had some early results too. I didn't show here because it really is pretty early at this point, but it looks like blood pressure drops the longer you're on prehabilitation. There seems to be some direct results kind of on that pathway of physical activity, weight loss, blood pressure control. And so those are the ones that we've looked at so far. We do have things that we could get into, if I can get into those notes again to pull some of this on balance, on walk speed, things like that we could get to.
All right, it looks like we were able to get through everyone's questions. We'd like to extend our thanks once again to Becca Brown and to Dr. Mara McAdams DeMarco for your time and for a fantastic presentation today. To all of our participants, we thank you for your time and for your interest, and we wish you a wonderful rest of your week. Thanks so much and take care.